this little bit complex region of the upper extremity is concerned, we cover this hand. It is very delicate, very intricate, and little bit complex than whatever the things we have studied in the upper extremity, like the upper extremity arm, forearm, and the chest region as well, portion of it, which is kind of superficial and kind of easy. This content, whatever you are going to cover today, is a hand, is little bit complex. You need some kind of like understanding, focusing on this particular content. Whatever the things we are studying or focusing in here, that's the content you will be focusing on. There are so many things are there in the books. We are not just like going to learn each and every detail of the hand, because whatever is required for our undergraduate level, following the curriculum, we will be focusing in here. So in hand, we will be covering this particular areas of the hand, what this particular area of the hand we are like addressing, which part of the hand, which are some domains of the hand we have particular address to it. We will be saying that what this particular parts is concerned. We will be going to see this particular cutaneous distributions of sensory supply to the hands. We are going to see this particular hand as terms of like tendons, whichever is coming in here, or muscle or neurovascular structure which are present on it, and how these particular muscles are behaving, so that we are getting the desired mode of joint action whenever the hand is performing the actions. As you are seeing, this particular hand is having this kind of parts. So we have this particular hand have got like fingers. These are, we call them as digits. By the digital thing, we call them as digits, and we number it 1, 2, 3, 4, 5. And we just like to say medial side, lateral side, according to our anatomical knowledge. This side of this particular hand we call them as palm. The opposite side we call them as dorsum. And this particular aid, we call this tip of it, we call them as pulp, or pulp space or pulp region of the finger, which is on the palmar side. And on this dorsal side we have these nails, which is fitted on this particular region. We call them as nail beds. So these are the regions on this particular region. Now if you are talking about the skeleton region of this, we have this metatarsal bones which is present in this particular palmar region, and then we have this particular fingers fitted with this phalanx. There are 3 of them in number 2, number 3, number 4 and number 5 digits, and number 1 digit, which is the thumb, have got 2 phalanx. We call them as how this particular phalanx are placed, like a proximal phalanx which is close to the palm, and distal one which is away from the palm. So based on this proximal phalanx and distal phalanx, and in between them we have this third one, we call them as intermediate or middle phalanx. This particular thumb have got 2 phalanx or bones inside to it. We call them as proximal and distal. Now between them we have the joints, we call them as interphalangeal joints, which are joining between them. So according to joints will be 2 out here, we call them as proximal interphalangeal joint and the distal interphalangeal joints, and corresponding that we have the skin folds which is present in here. And then we have this particular phalanx joining with this particular metacarpal bones out here, we call them as metacarpophalangeal joints. And then with phalanxes joining with this particular wrist bones, we call them as carpal bones, we call them as carpometacarpal joints. Likewise, so we have done this particular anatomy about this particular joints and bones. So we just like divide this hand for the descriptive purpose into 3 domains. So this region of this particular palm side, we call this as under this particular thumb has a elevation or bump, we call them as thenar eminence. Opposite to that, before or under to this particular little finger or pinky, we have another elevation which is present little bit lesser than this thenar eminence, we call them as hypothenar eminence. And between them we have a cavity, we call them as concavity inside. So these are the 3 domains in the palm region whenever you are seeing this particular palms in region: thenar eminence, hypothenar eminence and midline concavity. Now in this particular region of the palm, if you are going by these anatomical dissections, what we see here, we have the skin which is present in here. Deep to the skin we have the superficial fascia. Under that superficial fascia we have the deep fascia, and under the deep fascia we have this neurovascular structure which includes the muscle, which includes the nerves, which includes the blood vessels which are supplying to it, and deep down we have the bones, how this particular things is there. We might have some kind of spaces there, we have some tendons, we have some kind of muscles which are present in this particular regions. So beyond this particular wrist joint, we have this particular area limited by these particular digits. We call them as palm or palmar surface. It has two surfaces over here, which is you are seeing here is palmar surface, and the back side we call them as dorsal surface. And these particular three prominent regions, elevations on the two sides, and the central side we have a depression. Now, if you go by these particular structures in this particular palm region, we have the skin, fascia, deep fascia, muscles, spaces, bones, etc., etc. Now, out here, point of concern here, the deep fascia of the hand or palm region is little bit complex than there are deep fascia from the of the other region. So deep fascia of this particular hand region is fragmented or divided or subdivided into three categories. We call them as retinacula, which looks like a wristband, which is present around the wrist. We call them as retinaculum. One is present on the palmar side, we call them as flexor retinaculum. Other is present on the dorsal side, we call them as extensor retinaculum. They are wristbands. Then we have this particular central part of deep fascia, which is occupying here, we call them as aponeurosis. We call them as palmar aponeurosis. This palmar aponeurosis goes to these fingers. Now, once this particular palmar aponeurosis goes to the fingers, we have a special name to this particular part which is present or covering the digits. We call them as digital fibrous flexor sheaths. So, they are all deep fascia. So, this deep fascia needs a little bit discussion whenever we are talking about. Then we have the muscles which are present in the thumb in this region, we call them as thenar region. Deep fascia muscles present in the hypothenar region, and rest of this particular palm have got muscles. There are some spaces, some kind of neurovascular structures which is present in here, nerves, blood vessels, etc., etc., and bones likewise we talked about. So, let us talk about the skin, about this particular palm. And first thing to talk about the skin, the palm region is supplied by or richly supplied by nerves. Now, this particular palm region is supplied by the skin, we call them as cutaneous nerve, which picks up the sensory sensation, that means touch, pain, temperature, etc., etc. So, these distributions of this particular cutaneous skin or cutaneous supply of the palmar skin, we have to just like remember very well. So, we have this particular dorsal side and the palmar side of this particular skin of the palm, how it is innervated, that we have to keep in really well, keep in mind really well. So, let us talk about this particular palmar side first. In this particular palmar side, this particular thing is divided into 3.5 and 1.5. So, we have this particular thumb side along with this particular two digits with the half of this ring finger makes this particular 3.5 along with the 1 and 3.5 of the palm. This region which is colored with this particular pink shadow is innervated by the cutaneous branch of median nerve. Opposite to it, we have the 1.5 of this palm region and 1.5 of this particular left of this particular fingers. The skin over this region is supplied by this particular cutaneous branch or skin branch of ulnar nerve. So, this ulnar nerve and this particular median nerve cutaneous branch, that means they are superficial, they are supplying this palmar region. Now, not only this particular supplies over this particular palmar side, this particular cutaneous branch of this median nerve and ulnar nerve flips to this particular dorsal side as well, that means on the back side. You see that up to this particular nail bed of this particular distal interphalangeal joints over this region as well, on the medial nerve supplies to this particular 3.5 fingers, and in case of this ulnar nerve on this dorsal side, it supplies this particular entire region as well. So, we have this particular purple shadow which is covering the ulnar nerve cutaneous distribution on the palmar side and as well as on the dorsal side. Now, left over on the dorsal side is that which have the different colors, which you see that with this particular yellow shades, which is supplied by the cutaneous branch of radial nerve. Now, these are your exam questions. We usually just like give the pictures or ask you to describe the cutaneous supply or cutaneous skin innervation of this particular hand region. So, whenever it is given the word of the hand, that you have to address the palmar side and as well as dorsal side. And once you write it or demonstrate, you just like give a schematic picture like this as a schematic drawing, and again you draw this particular medial, lateral, above, below like that. So, this particular cutaneous innervations of the skin of this palm region both in the palmar side and as well as dorsal side are very important, and likewise we get the clinical question based on these particular innervations. Now how? Now for example, as a physician you are encountering a patient who has a nail bed infection of this middle finger. Get it? So you have a patient coming with the injury of this particular here on the middle finger nail bed. Now you have to do surgery or you have to do some procedures. Now to do the procedures or surgery, you have to anesthetize the patient to give a painless feeling of painless regional thing for the purpose of the surgery, or else if you are just like hurting the patient while doing any procedure, the patient won't be cooperating with you. So for that reason you have to anesthetize, that means make this particular nerve numb or not feel anything. Then for that reason you have to anesthetize the nerve which supplies this particular region. So we have to know which nerve actually supplies the skin of the region, then you do the surgery. So if you do not know the what nerve is innervating or sensorily supplying that part, you cannot make this particular nerve innervated or numb and do the procedures. To understand the cutaneous thing is that whenever you are doing any surgeries or doing anything, you have to cut the skin or modify the skin or do anything, you have to just anesthetize the nerve which is supplying to it. So this is why this particular cutaneous innervation or knowledge is required for us to do the procedures. Now taking from this particular skin, we have the superficial fascia on this particular palm or hand region. Out here, only important thing that needs mention, in this cutaneous region or this palmar region, we have a superficial presence of a muscle. We call them as palmaris brevis, which really related to this particular thinner region and stays over here. So this nerve which is present in this particular palmar region, we call them as palmaris brevis, which is present in this cutaneous region or superficial fascia of the palm. And this palmaris brevis helps to have a grip. If you just like look at your hand, if you just like extend or make this particular region, you can see that there is a kinking or folding of the skin on the palm region. And that particular folding is because of this cutaneous skin or subcutaneous muscle which is present in here, which call them as palmaris brevis. And that's it about this particular superficial fascia that you have to understand in this palm region. Now from here we are going to talk about this particular important aspects of the palm region, we call them as deep fascia. So deep fascia of the palm needs or have some little bit complications and little bit I would say like modifications. So this particular deep fascia of the palm is modified into three different manners in three different regions. So one in the wrist region, the deep fascia of the palm is modified to form a wristband kind of structure. We call them as retinaculum. So if the retinaculum is present on the palm side, we call them as flexor retinaculum. If this is present on the back side, we call them as dorsal retinaculum. We have this particular palm side and this dorsal side retinaculum, which is visible. I am pointing over this dorsal side retinaculum. We call them as dorsal retinacula, and this side we call them as flexor retinacula. Also this dorsal side is known as extensor retinacula because it is present on the extensor side of the forearm. Now this is one thing. Then the central part of the palm is occupied by the deep fascia. We call them as aponeurosis, which is a triangular structure. We call them as palmar aponeurosis. It has some importance as well. Now as this particular palmar aponeurosis moves to this particular fingers, this is little bit again modified and little bit separated from the wrist part of this particular palmar aponeurosis. We call them as fibrous flexor sheaths, which are present to the fingers. And this is present on the fingers, that's why we call them as digital fibrous sheaths. So three things are there, we are going to talk each one at a time, and each of them are important to us. Now let's take about this particular retinacula first, and this is what we are going to talk in detail about it. Now move to this particular retinacula, which is present on this particular area. We see that joining this particular thinner eminence bottom side with the hypothenor eminence. So this side we call them as flexor retinaculum, which is present on this side, so which is here. Now another side we have this one, we call them as extensor retinacula. Out of these, the flexor one is more clinically important and we have to know about this thing for the clinical results. Now you see that this particular flexor retinacula, which is extending like a wristband between these particular bones. We call these bones as a carpal bones, and present over these regions and encasing or covering this particular region and joining this particular covering bones over here. You see that it is marked over here 1, 2, 3, 4. So these are the different carpal bones that are present on the medial side and the lateral side. So you see that this is present on the medial side, which is number 3 and 4. So which is extending between this tricolateral bone pisiform and hook of the hamate, 3 and 4 over here. And then on this particular lateral side is extending between the scaphoid and trapezium bone. So this is a deep fascial expansion which looks like a band, quadrangular square structure present on this particular over the carpal bones and on the flexor aspect. We call them as flexor retinacula. So this is about the description of it. Now why this particular structure is important? Because this particular structure is important. This is present in the gateway of this particular forearm and the arm and the hand. Now the tendons and the neurovascular structure as it is passing from this forearm and reaching to this particular palm region, they have to travel either under them or go above it. So if you have the neurovascular structure, that means median nerve, ulnar nerve, the radial artery and the ulnar artery, they have a choice between this particular point. So either they have to go under it and enter to this particular palm region, or they have to jump over the retinacula and reach to this particular palm region and then distribute and supply. So different structures behave differently as they are encountering this retinacula. Some of the structure are going under this retinacula, some of them are jumping over. Now what we have to keep in mind, what structure is going below and what structure is going above this particular flexor retinacula to reach to this particular hand. Am I clear what I am trying to say? So of this, as this is traveling through this particular gateway under this particular retinacula or above it, we have a consequence or disease presenting to us. Now let's understand what are the structure that is running above and what are the structure that is running below. Now the structure which is jumping above on this particular, on top of this particular retinacula are mostly the cutaneous nerves, which are going to supply the skin of the palm. Now what cutaneous structure passes through this? The cutaneous branch of radial nerve, ulnar nerve, the cutaneous branch of median nerve. They are running over and supplying the skin. What other structure that covers or passes above? This one which is running on this side, we have the blood vessel. We have this ulnar artery running over here and moving out, and as well as the ulnar nerve. So ulnar nerve, the main trunk, along with this particular cutaneous branch, along with this particular ulnar artery, passes above this particular flexor retinacula. And what structure runs deep here is that the tendons which is ending on this particular fingers, we call them as digital tendons or long digital tendons, they are going under along with the median nerve. So this is what we are trying to say. This is the dissected part of this particular forearm at the junction of the palm and this particular forearm region, and this is what we have exposed out here, the retinacula, the white band over here. Now you see that under or deep to it, we have this particular long tendons of these fingers. We are going to see these tendons which are coming from the forearm, like flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis. They are going under this particular retinacula. And going above here, on top of it, is this particular vascular structure or neurovascular structure. This is what we have the ulnar side, this is the radial side. This ulnar side, we have the ulnar nerve and ulnar artery. They are jumping above this particular retinacula. So this superficial to the flexor retinacula, that means they are not going under to it, they are jumping above. What are the structures they are jumping above? The cutaneous branches, the palmar cutaneous branch of median nerve, this one which is jumping above, supplying. Then we have the palmar cutaneous branch of ulnar nerve and main ulnar nerve and ulnar artery. These are the prime content which are jumping above this along with the flexor carpi ulnaris tendon. So they are going above this flexor retinacula. What are the structures that going under to it? all the long digital tendons. You see that? So this is the cross section of the hand wrist joint you are seeing here. This is the carpal bones making the floor of it. This is the retinacula which is bridging on top. So this particular tendons which you are seeing here, number 2, number 3, they are digital tendons like flexor, digitum, profundus and superficialis, along with this particular nerve which you are seeing here, number 1. So this noun number 1 is a median nerve which is going under the retinaculum, which is passing through. So these are the prime content that is passing deep to the flexor retinacula. So this is what you have to remember. Number 1 thing is median nerve, which is number 1 that we have to keep in mind. Next is flexor digitum superficialis, flexor digitum profundus. Then what? Flexor pollicis longus, which is on the pollic side, and flexor carpi radialis. So these long tendons which are passing under this flexor retinacula, and along with that, one soft tissue structure that is running here is number 1 is median nerve. Now this is what you have to remember, what structure goes under to it. Now why? Now see that these are the bones and these are the tissues which is covering over here is deep fascia. So we have these bones over here and tissues over here. This particular flexor retinaculum is a very tough, thick structure. You cannot just like cut it or just like mobilize it. It's really tough. Now this particular compartment which you're seeing here is very, very delicate compartment and very tight present. Now if you have any excess accumulation within this particular compartment, say for example, if you have a blood accumulation, fluid accumulation, or this tendon becomes swollen up, or if you have any growth happening here, the space inside to it gets cramped. So if you have the space which is occupied by some structures, say for example, if this particular bone grows a little bit more, or if you have some sort of things growing in here, so that is going to compress the structures in here. Now this particular space which you are seeing here looks like a tunnel which is present on the wrist region formed by these carpal bones. So this particular tunnel which is giving an entry from the forearm to hand, we call them as carpal tunnel. This carpal tunnel is formed by these particular bones in the floor and above this particular flexor retinaculum above, and they are inflexible structures, the bones and this particular retinacula, both of them. So if you have anything occupied in here, it can compress this particular structure out there. Now out here what we have is tendons and a nerve. Now out of this tendon and this nerve, the nerve is vulnerable. That means nerve is weaker one. So if you have a pressure on this nerve, the nerve falters to perform the actions. Now what nerve lies here is the median nerve. So if this median nerve is cramped, the median nerve cannot perform or cannot function. Now if the median nerve cannot perform, cannot function, that means the muscles that are supplied by the median nerve in this hand region and the skin which is supplied, that part which is supplied by the median nerve, is not going to behave or not going to work. And that particular clinical thing or clinical symptom that is presented out of compression of the medial nerve in this tunnel region, we call them as carpal tunnel syndrome, right? So we call this particular clinical condition as a carpal tunnel syndrome, where you have this carpal tunnel content is cramped by any reason. If you have blood accumulation, fluid accumulation in here, if you have any excess growth of the bone which is down here, squeezing this particular content, and out of this particular content which is present in here, the most delicate is number 1. What number 1 is median nerve, and that particular nerve, if it is compressed, we have symptoms accordingly. What symptoms we have? The muscles which are supplied by it and this part of the skin which is supplied by this particular median nerve are going to be affected. Clear? So this clinical symptoms is presented as carpal tunnel syndrome, which is very frequently tested in examination. Explain why something like this happens in this carpal tunnel and median nerve compression. Or you have something, a feature like sensory symptoms over these 3.5 fingers, and you have trauma in this particular wrist region, etc., etc. So you have to just like describe this particular carpal tunnel how this carpal tunnel is formed, what are the significance of this carpal tunnel, and why this particular median nerve is cramped, whereas the ulnar nerve is not. Why this ulnar nerve is not crammed in here? Because it's not existing in here. How come the ulnar nerve escapes it? Because ulnar nerve runs on top of it. It escapes this particular carpal tunnel. It chooses to reach to this palm region by bypassing this, by running it above it. So it is bypassing it, not going under it, rather it is going above it. Now, this median nerve is deep lying structure, as it is going under the tunnel. The ulnar nerve is superficial to it. Now, the ulnar nerve is bypassing this carpal tunnel. That makes this particular ulnar nerve vulnerable to injury if you have superficial cut. That means, if you have a cut injury, superficial slash injury to the ulnar side, the nerve will be damaged, whereas the median nerve will be spared. Why? Because median nerve is deep seated, deep under this flexor retinaculum. So you have to just like stab it really deep to get this injury to this injury to this particular median nerve, whereas the injury to this ulnar nerve in a superficial cut is important or very frequent or common. So in an exam question, they trick it by giving this particular two different clinical situations. One is, we have to understand which one is superficially running and which one is deep running, and why we are calling it superficial and why it is running deep. So this particular superficial running structure is ulnar nerve because it is not going deep. If it is going deep, then it has to go under it, but it is coursing above it. That's how it is escaping this particular cramping or cramming into this carpal tunnel. But whereas if it is passing above, it cannot avoid the superficial injuries. So these two injuries of the ulnar nerve and this particular median nerve comes in two different sequences of the injuries in the wrist region. One is deeply placed, where this particular carpal tunnel is cramped. Then we have this particular problem which is presented out here is because of the carpal tunnel syndrome. And if you have this superficial injuries into this particular region, we have this particular ulnar nerve injuries. So this particular areas frequently being tested in examination. Prepare this very well for your examination. Carpal tunnel syndrome and consequence of this, and the injury to this particular superficial part of the wrist joint to this particular ulnar side, leading to this ulnar nerve injury. Extensor retinaculum, just like flexor retinaculum, we have this extensor side tendons wrapped by this particular band, which we call them as extensor retinaculum. So that much of knowledge which is existing on the extensor retinaculum is covers us, because that not clinically important. It is existing and holding this long tendon or long extensor tendon on this side. That's it. This much of knowledge is good enough. So we focus on this carpal tunnel and carpal tunnel problems, or the clinical problem, we call them as carpal tunnel syndrome. Now coming from here to this complex part, again to this particular deep fascial modification, number 2, we call them as palmar aponeurosis. That means the second part of the deep fascia of this palm region. This central region, this deep fascia, we call them as deep fascia of the palm, also known as palmar aponeurosis. We call this palmar aponeurosis as because it is flattened. So this particular palmar aponeurosis present in this particular region, flat regions, we call them as palmar aponeurosis. If you cut this palmar aponeurosis, then only we can see the structures deep to it. That means neurovascular structure, muscles, tendons, etc., which can be visible. Now you can see this particular palmar aponeurosis looks like a triangle. So this particular triangle, this is the apex side, this is the base side. Now this particular apex side of the palmar aponeurosis blending with this flexor retinacula, and this distal side which is becoming fanning out, broadened, meeting with this particular sleeves which is going to the fingers. These fingers we call them as digital fibrous sheaths. So this particular palmar aponeurosis which is present in the central region sometimes may be contracted. So this particular palmar aponeurosis on this side may be contracted from some reasons. We call them as Dupuytren contractures. So sometimes if this particular palmar aponeurosis contracts, that leads to the flexions of the fingers like this. So we call them as Dupuytren contractures. So it happens post burn, It happens in case of the alcoholic patients. We do not know why, but this kind of contractions of the palmar aponeurosis, if it happens, we call them as Dupuytren contraction. So this much of palmar aponeurosis we must be knowing. Next, move to this third part of this deep fascia, which is this one. So this particular deep fascia, which is reaching to the fingers, has a special entity. We call this deep fascia, which is covering the fingers. We call them as digital fibrous flexor sheaths. So you look at this particular pictures and follow this particular green thing. So this particular green one, which is covering the fingers like a tunnel, we call them as flexor fibrous sheath or digital flexor fibrous sheaths. So this is nothing but the deep fascia of the fingers. So under to this particular region, under to this particular superficial fascia, we have the deep fascia, and deep fascia of the fingers we give this particular special name. This is what we have to know. Now, once you have appreciated this particular green shadows which you are seeing here as the deep fascia of the fingers, under to it we have this particular bluish shadows or bluish covering areas which you are seeing here. So this particular blue or thin blue kind of things or sleeve-like structures which is present under this flexor fibrous sheaths, we call them as synovial sheaths, also known as digital synovial sheaths. So synovial thing we commonly see in case of these joints, we call them as synovial joints, right? So in case of this particular hands, we have an additional modifications out here. We call them as digital synovial sheaths. Now this point you have to just like focus here because this is important for us to understand the next part of it. So what we are talking here is the deep fascia of the hand or palm region. So deep fascia of the hand or the palm region have got three special characteristics. One is the retinacula we talked about. Second is the palmar aponeurosis we just spoke about. The third one we are dealing out here is this one. Now unless until you understand in here, you won't be able to understand on yourself by reading the books because it's too complex. So you just focus in here, later on you can just go back and study on your own and then you will be understanding. So we are focusing on the third element of the deep fascia of the fingers or deep fascia of the palm. Now in here the deep fascia of the palm, which is the green one we seen there. So under the green one we have the blue shadows or blue coverings. So these blue coverings we call them as synovial sheaths, and it is covering these fingers, we call them as digital synovial sheaths. Now this is a special entity. Now why this particular thing is a special? Now if you look our like a palm, inside the palm we have two different types of muscles. We call them as intrinsic group which are present inside the palm, and other one we call them as extrinsic group. This is A and this is group. So the palm muscles which can be categorized, can be divided into two groups. One is intrinsic, that means they are originating and ending within the palm itself. And some of them are coming a long course and entering to the palm region and ending in this region. So what are the long muscles which are coming? We call them as extrinsic muscles. They are coming from where? They are coming from forearms. So what muscles are coming from forearms? These particular muscles which are going to the digits. So we call them as digital tendons, and these digital tendons we call them as flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus. These are flexor indices. So is the extensor muscles. So these are forearm muscles, they are coming, we call them as long tendons. Now these long tendons are really strong. That gives this particular strength to the grip, whatever things we are making or holding in the palm region. So these intrinsic muscles are for delicate actions. holding the pen, buttoning the shirt, making the piano moves, music players. These are intrinsic actions. They are very delicate, very sophisticated muscles. But the mechanical things or the muscle strength of the palm or holding it or gripping it or lifting it, this gives the strength that comes from the long tendons. They are coming from all the way to forearm. And they are running either under or above this retinacula to reach to this particular palm side. Now, these particular tendons, as they are providing very strong grip, they need a special kind of wrapping so that they can perform frictionless. So, they do not mix up with the intrinsic muscles. So, they can perform this particular high voltage actions or deep performance without any kind of interference by these intrinsic muscles. So, these long tendons of this particular forearms which are reaching to the palm or extrinsic muscles of the palm which are going to the fingers, they have a wrapping, that particular wrapping which is made of synovial sheaths. Now, this particular synovial sheath is a kind of very uncommon rest of part of this. Synovial sheath we usually see in kinds of like joints or in a synovial joints. So, this synovial joints makes this particular element special. Where this particular synovial sheaths are there, they are under the deep fascia. Now, what the deep fascia of the fingers we call them as? We call them as flexor fibrous sheaths or digital flexor fibrous sheath. So, if you cut the deep fascia of the fingers, under to it you see this particular glistening part of this particular synovial sheaths. Now, this particular synovial sheaths which are present, they can be or they are of three types. We call them as bursa. So, this synovial sheath we give a special name, we call them as bursa, B-U-R-S-A, bursa. They are for the cushion. Now, one is present on the radial side, we call them as radial bursa. One of them are present on the ulnar side, we call them as ulnar bursa. And the third one going to the digits only, we call them as digital bursa. So, these bursas are our exam questions. So, we have to understand what do you mean by this ulnar bursa, radial bursa, digital bursa, where exactly they do exist and what are the functions of this bursa and what turns bad or what turns disease if you have a diseases of the bursa. That is what we are going to talk. Now, once again, so we are talking about the deep fascia. We are talking about the deep fascia of the fingers. Now, deep fascia of the fingers we call them as flexor sheaths, digital flexor sheaths. Now, digital flexor sheaths which is covering or present on the fingers. Now, this particular fingers is fitted with these long tendons. We call them as flexor digitorum superficialis, flexor digitorum profundus. They are the power things for the fingers of the grips. Now, this particular finger or long extensors or flexural muscles, they have a covering surrounding it. We call this surrounding which is covering these tendons which is present under this particular deep fascia of the fingers as synovial sheaths. Now, these synovial sheaths we give a special name, we call them as bursa. Now, this bursa can be of three types. One of them are present on the ulnar side, radial side, and some of them present on the fingers. So, based on this how they are present, we call this as a bursa. Now, we just like to talk about bursa. If we just project it, that makes this particular thing is clear about this particular bursa. Now, this is what we call them as synovial tendon sheaths of the fingers. Now, you see that this particular picture focus in this particular region. So, this is the phalanx bone which is present. On the top of that, we have the tendon of the long fingers coming. That means FDP and FDS, they are coming. Flexor digitorum profundus and flexor digitorum superficial, they are coming. Now, surrounding them, we have this particular blue coat which is covering here. So, this blue coat over here, we call them as bursa as they are present. So, this particular synovial sheath which is covering here, we call them as bursa or synovial bursa. Now, on top of that, we have this particular deep fascia of the fingers. Clear how this? So if you're cutting the skin to reach to this bursa, how you're going? Skin, superficial fascia, then you are getting this particular deep fascia of the fingers, fibrous sheath, you cut that, then you get this. Then cut this bursa or this flexor sheaths which is present on the synovial side, we get the tendon. Clear? So this is how superficial to deep it is there. Now this is what we are talking about, the bursas, they are present in 3 different directions. Now from here we are going down. Now this particular synovial covering which is wrapping around this particular long tendons, they are going in this ways. So some of them are going to the radial side and covering this particular tendon of the flexor digitorum, flexor pollicis longus, going by the thumb. So covering this particular thumb, the tendon or long tendon, there is a bursa which is going on the radial side. This bursa we call them as radial bursa. Now other one which is going on covering this particular flexor digitorum profundus and superficialis which is present in here. So you see that this nature of this bursa, how it is going and reaching to the palmar space and then it is narrowing down, tapering and continuing only to this particular little finger. So this bursa we call them as ulnar bursa. So this ulnar bursa and radial bursa which is present on 2 different sides, ulnar side and radial side, they are covering this particular tendon. So what this ulnar bursa is covering? It is common synovial sheaths, it is little bit separated out, extends to the little finger on the ulnar side which is going to here. It is only extending to here. So these 2 bursas are there, ulnar bursa and radial bursa. Now look at this particular fingers, like finger number 2, 3 and 4, they are present. They are having this particular bursa, but this bursa is separated out or fragmented out. They are not continuous with this ulnar bursa or this particular radial bursa. So this element is little bit different than that of this one and that one. So altogether we are getting 3 different bursas: radial bursa, digital bursa and ulnar bursa. Now what we have to know, what this particular digital bursa is covering, what this ulnar bursa is covering and what are the clinical problems we are encountering. So this particular ulnar bursa is covering this particular long tendon which is reaching to this particular little finger only. This particular bursa which is radial bursa, which is again synovial sheath, covering this particular finger which is going to the long tendon of the thumb which is covering this particular flexor pollicis longus. Now what we are left with, this particular digital bursas which is present in here, they are short, fragmented and not communicating with the rest of this, neither ulnar bursa or radial bursa. They are independent, but they are present covering these things. So they are separated out. Now why we are spending time to understand this? Now reason is that this particular bursa can be infected. Infected how? If you have infections in these fingers. Now many a times you have seen or learned that to do a glucometer test to assess the blood glucose, we make a pin prick. আমরা pin prick করে glucometer sugar দেখি, random blood sugar, fasting blood sugar দেখি. So we do make this pin prick. So while doing this particular pin prick is that we just like pierce the skin and take the blood out and assess this particular blood sugar level by through some machines or meters. Now if you are pricking this particular fingers through a unsterile needles, there are chances of infections to these fingers. Now if you have finger infections that can reach into this particular bursa, can spread out to other fingers and can spread out to hand and lead to a very disastrous conditions. How? Now if you are pricking the skin of this little finger, so you are pricking the skin with the unsterile needle with the little finger and this particular infection affects this particular little finger, and this particular infection once reaches to this particular synovial sheath inside to it, it can travel through this particular bursa and reach to this particular palm and to reach to this particular forearm. Now unfortunately this particular ulnar bursa is communicated with this particular radial bursa. How? We have a communication between this particular ulnar bursa and the radial bursa. So this particular infections from this particular radial bursa and ulnar bursa can spread from this particular little finger to this particular thumb. So you have pricked the skin of this particular unsterile little finger and ended up in having infection spreading to the thumb, eventually passing through this particular palm region and reach to this forearm even. So that's why this extension knowledge or extensive knowledge of this particular bursal spread is important to us. Now this is the reason we choose to prick these particular fingers for these three fingers only. So whenever you are testing this particular glucometer test, we restrict this particular pricking of the skin of this particular index finger, middle finger and ring finger. Why? Because you see that these synovial sheaths are discontinuous. So if you have infections by any chance with the unsterile needles, you are making this particular finger affected only. So infection from this index finger, middle finger and little finger cannot spread beyond these particular fingers. So it is a restrictive manner. That's why whenever you are picking these particular fingers, we are choosing this 1, 2 and these 3 fingers only, not choosing this particular thumb to take this particular test or these particular ring fingers. So the infection from this little finger can reach to this particular thumb by passing through this particular bursa. As this particular bursas are communicated from this thumb as well, it can reach to this particular little finger. So whenever we are making some kind of needle prick to these fingers to test anything, we choose this index finger, middle finger and little finger and avoid this thumb finger and as well as this pinky or little finger for the needle prick test. And this is the logic is that because the bursas of these 3 fingers, which is digital bursa, and it is limited to this particular fingers only of the respective one and not communicating neither with the radial bursa and ulnar bursa. If they are communicated by any chance, then that would have spread these infections to a point beyond control. So isolated digital sheaths or isolated digital bursas are present, index, middle and ring. That's why for the needle prick we choose this, avoiding this thumb and the little. So this logic of choosing over these fingers, we have to explain anatomically whenever you are giving the clinical questions. Or maybe they are asking the clinical question, the infection from the little finger can spread to thumb. Explain how, explain why. Infection of the thumb can spread to little finger, not to middle finger. Explain why. Get it? So this logic of these particular extensions of the bursa helps us to understand how the infections from the fingers can spread to the palm, to the forearm and to other fingers, yes or not. Okay? So this is what our anatomy knowledge helps us. So this is sheaths which you are seeing here, continuous. If you are dissected out, covering these things, the blue one is this particular synovial sheath, of the middle one is limited, as you are seeing there, whereas this particular little finger and the thumb, they are continuous at this level and can reach to the forearm. So a finger infection from here and here can reach to the palmar space and can reach to the forearm even if they are not treated. Whereas infection from this one are limited to these fingers or restricted fingers only. Clear or not? Did you listen or did you fall asleep? Half sleep, half awake? Okay. So this is what we are seeing here. The ulnar bursa and the radial bursa reaching at the forearm, they are communicated by intercommunicating bursas. That's why this infections can spread from right to left, left to right, thumb to little, little to right. Alright. So this is what you have to explain it related to this particular radial bursa. What does it contain? It contains the flexor pollicis longus, and ulnar bursa contains this particular long tendons of flexor digitorum superficialis and the flexor digitorum profundus of this one, and the digital bursa is continuing with this. So these infections, if it is reaching to this right side to the left side, eventually going to this particular region, we call them as horseshoe infection because it looks like U. So this infection we call them as horseshoe shaped, that's why horseshoe infections. So this is how it looks like, taken from the book Natters. So radial bursa, ulnar bursa, digital bursa, and how they are communicated. Now from here we are talking about the muscles of the hand. We talked about the muscles which are extrinsic muscle. We understand what we mean by the extrinsic muscles. We are focusing this particular class for the palm region. We call them as intrinsic muscles of this hand region. So intrinsic muscles of the hand, that means they are present inside, housed inside the hand. They are not outside. Body moddhei ache. So that's why we call them as intrinsic muscles. Now these intrinsic muscles of the hand can be categorized into three categories. If they are present on the thenar eminence, if they are present on this hypothenar eminence, and others. So the muscles which are present under the thenar eminence, hypothenar eminence, and rest of it. So we classify it: thenar muscles, 3 of them; hypothenar, 3 of them; and others, lumbricals and interossei. So these thenar muscles, hypothenar muscles, lumbricals, and the interossei, these are the 3 different muscles. Thenar muscles. So they are present in here. 3 of them. We call them as abductor pollicis brevis. We call them as flexor pollicis brevis. We call them as opponens pollicis brevis. There are 3 of them. They are present under this particular thumb thenar eminence. So this particular muscle, 3 of them present in here, supplied by the branch or motor branch of median nerve. So the median nerve supplies all the muscles, 3 of them, present in the thenar muscles. So 3 of them: abductor pollicis, you have to know the names; flexor pollicis, pollis by the thumb; abduction means doing abduction; doing flexion, that means bending it; opponents, that means they are closing or opposing it, touching this particular fingers. So if you are counting these fingers like this action we call them as opposition. Now they are supplied by this median nerve. This branch of the median nerve which is supplying here, we call them as a recurrent branch. So if you cannot remember the recurrent name, this median nerve is good enough to understand this. Now under this particular thenar muscle, we have another muscle, we call them as adductor pollicis. So which is present in this side, adductor, this one. So that particular thenar muscles, these 3, under to it we have another muscle, we call them as adductor pollicis, which is supplied by other nerve like ulnar nerve. But the thenar muscles we principally restrict to this particular 3 of them. Hypothenar muscles, just like 3 of them is thenar side, 3 of them is on the ulnar side. They are named accordingly at the same way: abductor digiti minimi brevis, flexor digiti minimi brevis, opponens digiti minimi. So likewise they are named here: abductor pollicis, flexor pollicis, opponens pollicis. They are named accordingly: abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. So it will take some time to memorize this, but they have the same sequence of names over here. They are supplied by ulnar nerve. So all these hypothenar muscles are supplied by ulnar nerve, and they are doing the actions which is present. Other than this, we have this particular muscles which are called them as lumbricals. They look like worm, the worm, Ascaris worm. So they are named at 1, 2, 3, 4 like this. So from this particular thumb side to pinky side, they are numbered at 2, 3, 4, 1, 2, 3, 4. So these lumbricals 1 and 2 is supplied by median nerve, and 3 and 4 is supplied by ulnar nerve. So lumbricals number 1 and number 2, they are supplied by median nerve, motor branch of median nerve. And 3 and 4 lumbricals, they are supplied by, or lumbricals, they are supplied by ulnar nerve. Then we are left with interossei. Both the dorsal interossei and ventral interossei or palmar interossei, they are supplied by all of them, B dorsal, B palmar, they are supplied by ulnar nerve. So this particular interossei, they are doing abduction, adduction of the fingers. If you are just like making this particular finger go wide, spread and come close, abduction, adductions of the fingers, they are done by these particular fingers, like muscles, we call them as interossei. So to summarize the thing of intrinsic muscles and the nerve supply, we categorize them: thenar, hypothenar, others means lumbricals, 1 plus 2, 3 plus 4, interrossei, dorsal and palmar interosseae, 3 plus 4 together, all of them. So this along with this, so out of this, the intrinsic muscles of the hand, all the thinner muscles, 3 of them is supplied by the median nerve, along with lumbricals 1 and 2 by the median nerve, hypothenar and lumbricals 3 and 4, and all the intrinsic muscles which is present as interossei, dorsal interossei and palmar interossei, both are supplied by the ulnar nerve, all 3 entities. So majority of the muscles which is present in this particular intrinsic muscles in the hand, they are supplied by this nerve, we call them as ulnar nerve, and thinner and lumbricals 1 and 2 by this median nerve. So these are the distributions of these muscles, they are present in it. Now talking about the arteries in short, about in the hand. In the hand we have 2 sets of arteries, ulnar arteries and radial arteries. So ulnar artery and radial artery, eventually they make kind of anastomosis, we call them as arches. These arches are made or formed at the palm region, we call them as palmar arches. 2 of the arches are there, one is at the superficial plane, other is at the deeper plane. We call them as superficial palmar arch and deep palmar arch. They are contributed by the branches of radial artery and ulnar artery. So if you look at this schematic diagram, how this particular palmar arches are present, you see that the radial artery and the ulnar artery, both of them are contributing in a reciprocal manner in terms of forming this particular superficial arch. So we take this superficial arch because they are present to the close to the skin. So you see that ulnar artery, main artery, is taking majority or maximum part in superficial palmar arch formation, and a little contribution from the radial artery as a branch, a superficial branch of radial artery joining in here and completing the arch. The reverse thing is happening in case of the deep palmar arch. So majority of the deep palmar arch is formed by the deep branch of radial artery and a smaller contribution coming from the small deep branch of the artery which is completing the deep palmar arch. So this particular palmar arch or anastomosis between this particular ulnar artery and the radial artery taking place at different levels, we call them as superficial and deep palmar arches at different levels. So how does it look like? So this particular things look like ulnar artery, radial artery, they are contributing like this, they are moving superficial branch or superficial part, we call them as superficial palmar arch. If you dig deep, then we find another arch which is present like this, deep arch. So this deep arch and superficial arch, both of them are formed by this. If you remember this particular picture, that's good enough. Superficial palmar arch and deep palmar arch, they are formed by the superficial and deep branches of the ulnar and radial artery. Only thing that you have to keep in mind, the superficial arch principally formed by this ulnar artery. A little contribution from this counterpart radial artery, and reverse is in case of the deep palmar arch. That's it for these arches or content which are present in this region. Superficial palmar arch, deep palmar arch, and the content of which is related to this arch. Now, this is what we are gathering here for. Now, we have learned about this particular nerves, and let's talk about little bit about nerve injuries that is related to it. So, let's take one at a time about the injuries of these particular nerves, median nerve and ulnar nerve, which is the commonest nerve injured in the forearm and the wrist region. So, we take this particular median nerve first. So, median nerve injury or damage is most commonly happening under this arch. What arch? Carpal tunnel. So, this particular median nerve can get trapped under this carpal tunnel and compress this. So, what happens if you have the median nerve damaged in the carpal tunnel? So, we call this as carpal tunnel syndrome. So how to decode or how to understand the problem of these injuries to these particular nerves. There are two things which happens whenever you are decoding of nerve injury. So take this particular median nerve first. Now this particular median nerve, what kind of nerve it is? Sensory or motor or mix? What kind of nerve it is? Is sensory, motor or mix? Mix. Why it is mixed? Because it supplies the skin and it supplies the muscles. So now we are talking about the median nerve injury in the carpal tunnel syndrome, CTS. Now if you have the median nerve damage in the carpal tunnel, there will be affection of the sensory function, there will be affection of these motor actions. Now what action will be happening out here? So what muscles are supplied by median nerve in the hand region? What muscle in the hand is supplied by, or palm region is supplied by median nerve? What muscles are supplied by median nerve in hand? কোন মাসেল গুলোকে সাপ্লাই করে? সবাই হাত তোলো, হাত তোলো, হাত তোলো, হাত তোলো. Everybody raise your hand. Everybody. Everybody. Okay? Right. Now show me which is your forearm, which is your arm, and which is your hand. Okay. Good. Very good. I don't understand anything. But anyways, which one is hand now? Okay. Show me your hand. Okay. Ciao. Good. Now we understand what do you mean by hand? Understand? All right. So what muscles are supplied by median nerve in hand? First and second? All right. Anything else? Anything else? Thinner muscles. Are there anything more? How many thinner muscles are there? Do you know the names? Abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. So three of them, blah, blah, blah. Are there anything left which is going to be supplied by this median nerve? আর কোনো মাসেল বাকি আছে? হ্যাঁ না না? Yes or no? আর নেই, মনে পড়ছে না, আছে কি? নেই তো, নেই তো, তুই তো ভয় পাচ্ছিস কেন? বলবি তো নেই. Okay, so if you have a median nerve injury in this particular carpal tunnel, these muscles are going to be working or not? Not working. They quit the job. Sensory supply in hand. Median nerve do supply any part of skin in hand. Sensory supply আছে কিছু? Skin supply কিছু আছে হ্যান্ডে? কোনখানে? Sensation? কোন পার্টটা? Three and a half. All right. With tips of finger or nail beds. So it supplies the skin 3.5 fingers and 3.5 of palm or palmar surface. Dorsal surface supply করে ওটা radial. So if you have a median nerve injury, this sensory function is going to have or not? No. So if you have a carpal tunnel syndrome where this median nerve is cramped, these muscles are not going to work. So this particular muscle, thinner muscles will be weak, atrophied, and the sensory supply by this region, which is supplied by the cutaneous branch of blah blah blah, will be affected accordingly. But we have a twist in here in the sensory supply. What twist? Now sensory branch have got two things. One is superficial branch, other is non-superficial branch, if you just like make it in two ways. This superficial branch of cutaneous nerve of this particular median nerve runs above the carpal tunnel. You remember the branches above the carpal tunnel where you have the cutaneous branch of ulnar nerve, cutaneous branch of median nerve. So this particular superficial branch of median nerve which jumps above the carpal tunnel escapes the compression. So this particular superficial branch of median nerve supplies the 3.5 of palm. So a 3.5 of the palm will be spared in case of this carpal tunnel syndrome. Only the fingers will be affected. কারণটা কি? যদি আমরা চলে যাই আবার সেই প্রথম স্লাইডের দিকে, if you look at it, we have a branch, we call them as palmar cutaneous branch of median nerve, which runs above this superficial thing. So this particular palmar cutaneous branch supplies the palm. So as because it is jumping around, jumping above it, this branch is escaping the compression on this carpal tunnel. So only these 3.5 fingers will be affected in case of carpal tunnel syndrome. In this particular fingers distributions will be affected, not this particular ulnar nerve, not this particular main branches or superficial branch. So median nerve supplies whatever the things in this motor supply and this particular cutaneous region will be affected if you have a damage on this. Likewise, ulnar nerve, what kind of nerve it is? Sensory or motor or mix? Mix. So it has sensory, it has motor. So what muscles are supplied by this particular ulnar nerve in hand? Hypothenar, lumbricals, 1 and 2, 3 and 4. Okay, 3 and 4 are interossei. So these muscles are going to work if you have damage to it. যদি ulnar nerve damage হয়ে যায় এই মাসলগুলো কাজ করবে? It's not going to work. So they are going to get damage. Sensory supply, it supplies skin. Skin is supply করে where? 1.5 medial side, all of it. So this will be not working. So depending on how this particular things is working or not, they will be presented likewise. All right. So this is how we are going to see these particular clinical problems, how this particular element can be affected if you have an injuries to this particular median nerve and ulnar nerve injuries. So this is the easy way to figure out sensory damage, motor damage of this particular muscles and this particular sensory supply. If you have injuries to these particular muscles and as well as these areas, So ulnar nerve injury commonly happens if you have a slash injury in this region. So slash injury hoyeche, kete geche, churite keteche, glass pore keteche, these are the common thing. Ulnar nerve arekta kon jayagaye damaged hoy, there is the other side where the ulnar nerve can be damaged. We have this particular medial epicondyle behind it. If you have this particular thing, then it can be damaged as well. So depending on where this ulnar nerve is injured, we have a presentation. Say for example, you have an ulnar nerve injury in before it reaches or before it supplies to this forearm. So if you have a damage to this particular epicondyle before it reaches to this forearm, we might have injuries to this particular muscle which is supplying beyond it. What muscles is supplied beyond it? We have these forearm muscles and as well as hand muscles. Both will be gone. So forearm e ki muscle supply kore? Median ulnar nerve 1.5. So that muscle will not be good. Hand e ki kore? So the things is going to supply after this will be affected. Ki affected hobe? All the muscles which are supplied by this ulnar nerve in the hand region. What are they? Oi je thenar, lumbricals, interossei will be affected. Now, what will be the clinical problem presenting to it? Normally, if you have this particular injuries, they come to you. The clinical test, what we do, we ask the patient to make a fist. We ask the patient make a fist. Mutho korun. We ask the patient make a fist. We see that how they are making or completing the fist or not. So if you have this kind of ulnar nerve injury, we ask the patient fist and they makes this. So this particular sign where you have the incomplete making of fist, which looks like claw, we call them as claw hand deformity. So why this claw hand deformity? This particular fingers, if you are making this particular claw in this particular fashions, this particular region is supplied by this particular lumbricals 1 and 2, which is supplied by this particular median nerve. So that's why this particular median nerve is spared and this ulnar nerve cannot be spared, and accordingly this particular claw hand deformity, which is having this particular ring and this middle finger hyperextended and metacarpophalangeal joint at this particular end, it is pushed back, it is looking like this. So whenever you are asking this particular patient to make a face, they present like this claw hand look. So we call them as claw hand deformity, which is present in case of ulnar nerve damage. So we have the claw hand. Along with that, we have the sensory damage to this particular shaded region which you are seeing here. Moving to this particular ulnar nerve, to this particular median nerve. So we have this particular median nerve which is coming along with this particular region. Now, this particular median nerve can be damaged at 2 points. One is carpal tunnel we talked about. Other one is that at this particular region, we call them as supracondylar region. If you have fracture on this region, this particular median nerve running in this particular region, we call them as cuboidal fossa. Before entering to it, this particular thing may be damaged. So if you have a damage to this median nerve here or here, we have clinical presentations. What can happen? If you have damage to this median nerve here, anything of the muscles which is supplied beyond this will be damaged. So what muscles are supplied by the median nerve in the forearm will be lost. What muscle is supplied by the median nerve in the hand will be lost as well. So this particular median nerve damage to this particular point, we have the injury or muscle damage to this forearm muscle. What muscles are supplied by this particular median nerve in this forearm, in the front side? All of it except 1.5, right? All the muscles in the forearm supplied by it except this ulnar nerve which is supplying 1.5 only. So all the forearm muscles is not going to work. All the hand muscle which is supplied by the median nerve, which is thenar and lumbricals 1 and 2 is not going to work. So this particular person, when you have the injury here, they have the forearm muscle wasting or injuries or weakness, as well as this particular thenar muscle weakness accordingly. So if you have injuries out here, we have this presentation like this. If you have injuries in this wrist region, we call them as carpal tunnels. Then we have this particular injuries which is related to this particular carpal tunnel syndrome which will be presented. That means sensory symptoms and the motor symptoms. These muscles will be wasted, cannot form. This particular person has a difficulty in moving the thumbs because the thumb is moved by these things, right? So we call this movement of the thumb will be damaged or difficult, and the thumb will be opposed to this index finger. We call them ape hand deformity, APE, ape hand. Why we call them as ape hand? Because this is the position of the thumb and the movement of the thumb that makes us, help us to do sophisticated functions because of the opposition action. So if this particular thenar muscles is not working, our thumb is gone. Then the thumb will be attached to this particular index finger and will be present like this. And we cannot have a grip or do the sophisticated works which we used to do. So we became primitive, just like apes. The apes or chimpanzees or monkeys, they cannot hold the pain, do the sophisticated action. So our hand becomes ape-like hand. That's why we call them as ape hand deformity. So where you have this particular problems over these regions. So these two nerves are kind of injured in these spaces. One is supracondylar fracture, where you have this particular fracture above the elbow joint, where everything beyond that will be damaged, or wrist injury, carpal tunnel syndrome that we have talked on, discussed several times. Sensory damage will be on these particular regions of this shaded region of the median nerve sensory cutaneous supply. And this particular thumb position, we call them as ape thumb or ape hand deformity. Now, if you ask this particular person to make this fist, they cannot make a full fist, they make a half of a fist, because the ulnar nerve is working. So this side is, fist is made, and this side is remains as it is and looks like a Pope's hand. We call them as hand of Benedict's, or we call them as like Pope's hand deformity. So these are the injuries or median nerve sign injury signs which is present if you have damage to it. Other one we are left with this particular radial nerve which is present on the back side. Anything on the back side injury leads to the movement of the wrist which is damaged. So we have the wrist drop if you have the radial nerve injury. So these three common nerve injuries are commonly been given in examinations like carpal tunnel syndrome and claw hand, and this particular injury which is known as the radial nerve injury. We do not have radial nerve in here,